Well, thank you. I mean, that's such a hard act to follow, the amazing patient leaders we just heard from. And I do regard myself and the privilege I've now got of being nothing more than providing the tools and the preconditions for their success. And I kind of want to argue today that, for me, knowledge, data, are fundamental to the patient revolution that is so urgently required in our health service. And we should think of data not as some dry, technocratic, scientific, clinical record-based thing, though those are all very important. We should think of data as the pooling of our collective wisdom and our collective experience of healthcare in a way that enables others and ourselves to benefit in the future. It is literally about pulling the future into the present, so we can understand the outcomes people have, we can develop new ways of thinking about healthcare. It is precisely about liberating people that data is so important. And I just happened over the last week to have 2 Olympic experiences, which I thought I'd share with you. Because in a sense also, in that context, this concept of data being out the pooling of ourselves in order to help others. Perhaps the last time we really touched base with our values in a very visible way in healthcare was at the Olympics. And I was down at the Olympic site last week with Arvind Maidan, who's a GP who works for the Hurley Group. In fact, he's the chief exec there, and they run about 20 practices in really deprived parts of London. And this particular practice is no exception. It's in the building that was the health centre for the Olympics, where all the physios were based for the various country teams. Anyway, they've just recently opened this practice. They've got about 1,000 registered patients now, drawn largely from a population that are beginning to move into social housing and low-cost housing in what was the Olympic Village. And the distinctive thing about this practice is it is almost entirely digital. Of course, there is a physical presence. There are GPs, but people register at home online, and by preference, they all do it. And he's developed an approach to enabling people to even give their symptoms through a really safe, structured history-taking tool, which he's developed with his other colleagues, mainly, actually, because he wanted to save self-employed poor people time and avoid them having to come into the practice when they could give a really good account of their symptoms in a way a doctor could then triage and determine whether or not they were going to need treatment. And this really simple but brilliant insight, and in a sense, sharing data in a way which improves everybody's outcome, has reduced the number of people who are seeking physical interaction with their GP by 60%, which is just an amazing phenomenon. And of course, that tool is now being looked at very carefully by a whole range of GP practices around the country. But it's here we have an NHS leader, a patient leader. He's a doctor, but he's a real patient leader, trying to do the right thing by liberating the data in his community to serve the needs of everybody. And then over here, so one Olympic experience and perhaps a really important legacy. And then over here we have another legacy, which is mind-blowing and speaks a bit to Patrick's speech, which unfortunately I missed, but I've heard him before, and he's fantastic, which unlocks a different kind of liberation in ourselves. And this was the fact that, I didn't know this, but one of the really important investments that was made at the time of the Olympics was in 2 machines that were absolutely cutting edge in their use of molecular pathology and looking at molecules to spot banned substances in athletes. So this was the urine testing machine that was used, but it was literally revolutionary in its ability to be very, very granular about the chemistry of the people it was looking at. Now, those 2 machines have been taken from the Olympic site and are now living in Imperial College in West London, and they've been converted into the world's most powerful molecular pathology machines. And to give you an example of how fundamental this is to the liberation of data, they have recently established that there are in fact 10,000 molecules in urine, interesting fact, which I don't think I knew, and no one in the world knew until they started to have a look at it, of which only 2,000 are known to science, and they are now identifying a new molecule that is within ourselves each week. And the power of these new data is going to be, I think, literally transformational for healthcare. And of course, one of the big drivers for them exploring the opportunities of this new science is in relation to genes, genetics, the subject that Patrick was talking about earlier in the week, because the power of these data sets offers us a different kind of liberation, big data to really change the way in which medicine itself operates. So broadly put, I want to make the argument that big data is about unleashing the power of people in really tangible and important ways, and we are right in the middle of the world's biggest data revolution. The NHS leads the world in many respects in relation to really taking this agenda seriously, partly because we have such powerful patient voices who are demanding an end to the true scandal in our health service, which is ignorance. We do have some insight into our hospitals, but that's because for 10 years we have been publishing data on hospitals, and we've been transparent about that, which has been painful, but has been an important precondition, I suppose, for understanding where things are going right and where they're going wrong. But we do not have similar levels of transparency in pretty much every other care context we are commissioning. So if you think about things, for example, like cancer treatment, as we heard earlier, I couldn't tell you, nor could anyone in this room, right here, right now, how many people actually receive treatment for chemotherapy. We don't actually even count that fact. Certainly I couldn't tell you whether they were receiving that treatment with any useful benefit or not. We literally have no idea at all. We know very little about general practice. We know very, very little about mental health services, and we know almost nothing really about how social care and hospitals truly interact. We can't properly describe what happens to a patient as they travel through their journey of care, and that's the reason we have such a siloed, service-oriented health and care system. We are not people-oriented because we can't follow the person through their own vulnerable journey along our health system. So that's why I took this job. And it's also why NHS England has so prioritised this agenda. I think Simon in his speech talked about care.data. I'll just come to that in a minute. But this idea that we need to now start sharing data in order to properly understand what's happening to people so that we can liberate them in ways that were never possible before is now essential. And I should just, in a way, remind people why I got into this first as well. So some will know this story, but it's just worth in the context of hearing those amazing insights just earlier. Hear this maybe again in this context. So my mother was a GP when I was at the Sunday Times as news editor, and she rang me one afternoon in floods of tears saying that she was worried a local consultant radiologist was killing her patients. She had referred a number of patients with suspected breast cancer to the consultant, and nothing had happened, and the women had very sadly then subsequently died with no follow-up referral from the hospital. She wasn't sure what to do, and my experience of whistleblowers has universally been tragic. So I was an investigative journalist, worked with many whistleblowers, and there is no good thing that comes to people who are brave enough to break the bounds of their organisation and tell the truth. It is almost always a catastrophic emotional experience for those people. So I was inevitably, I suppose, quite concerned for my mother, and I didn't quite know what to say, but she had this very important truth which she wanted to expose, and so she chose to become a whistleblower. And she went to the authorities, an investigation ensued, and it was subsequently established that this consultant radiologist was an alcoholic. He had been literally stuffing mammograms down the back of his radiator and ignoring them. The inquiry said that up to 50 women may have had their lives foreshortened as a result of his negligence, but certainly 11 had, including the 3 women my mother had referred to him. The net result was he got struck off. In fact, I think he might now have been registered back in. I was going to check that before the thing, but he was struck off. And my mother was unfortunately hounded out of the hospital or the system in which she was working, as so often unfortunately happens. And I got into this data transparency game because the thing that most struck me was that all of that could have been avoided if the hospital in which this consultant worked had even bothered to check whether he was seeing his patients. I mean, this is a level of insight so basic that they weren't even using that data, quite apart from the other data they had, which would have told them that he was providing no useful service and his death rate was extraordinarily high. None of that was there, and I suddenly realized that we are completely flying blind, that the NHS, such an important, highly valued public religion, actually is offering a service it has on the whole, no idea of its quality. So I got into this and took this job after a long, decade or so of really trying to campaign for better data, because better data equals the patient revolution that we've just heard is so important. And one of the first things we did at NHS England was to launch, care.data, which is a program I'm sure everybody here will be familiar with. And I keep on being asked, is it a car crash? Was it a car crash that we chose to delay the programme earlier this year after a multiplicity of entirely justified concerns about the way it was being rolled out? And I just wanted to say to people that one of the most important conversations we all need to have is, if we are going to liberate ourselves as patients, citizens, managers, clinicians, if we are going to make the data revolution we need real, one of the most important conversations we all need to have is a conversation about the rights I have to my own data and how it should be shared. It's a really important conversation, and it just happened that that conversation had not occurred, has never occurred in any public service really, but certainly not in healthcare. And it just happened in February this year, and we, in a way, should be celebrating the fact that we're now having this conversation. So with care.data, the first thing, and sorry, for those who don't know, care.data is a simple ambition to link general practice data with hospital data so that we can start to determine what really happens to people between their GP practice and their hospital. We can start to think differently about service design, and of course we can also contribute to the development of new medicines and new interventions in a way which will unlock the future. But we paused it because there was just this enormous outcry, uncertainty, what was happening to my data, who was using it, and so on. Since then, a lot's happened. We've actually, 2 weeks ago, the Queen gave her assent to a new Act of Parliament, the Care Act, in which there are a number of really important safeguards now for people's data. And most importantly of all, it's now clear that this is our data. So the principle that it's us that have the right to decide how our data is to be shared, hopefully positively, because for all the reasons I've just described, it is fundamental to the future of our health service, we now have that choice. That's a really important thing. And the second thing is that data of this sort can only ever be used now for health benefit. So we can rule out the kind of emerging concerns that maybe people would use it for insurance or for junk mail or marketing. That is not legally permitted any longer. So those are some of the things that have been going on around care.data, but the conversation is much broader than just care.data. The conversation about how we, as people, can use our resources, our data, to support the future of our health service is really a big one for all of us. And that takes me to my sort of second point, which is one of the most important things I think about this data and knowledge revolution is not just us giving our permission to let our clinicians and our scientists do amazing things with our clinical data, but also for us to actually literally give our own opinion, our own feedback in a way which enables our clinicians and planners and others in the service to make sense of. So one of the other things we're doing, and we've started to do, is to try and find new ways of giving people proper real voice in real time on local services. And I guess people here will be familiar with the Friends and Family test. But the idea here, which this started last April, was to take a lesson from industry in giving customers, patients, the public, the opportunity to feedback in real time on local services and to rate those services like TripAdvisor as well. So you can rate your services, would you recommend it to your friends and family, and also give comment. And the amazing thing about this is it was launched last April, again, to quite a wave of skepticism, I have to say. I can remember doing my tour of the TV studios then and being told it was complete nonsense and wouldn't work. But a year or more later, and this is an important fact, a year or more later, more than 2 million people have volunteered comments about their local services and rated their local hospitals. And I think that's an amazing number of people. And I think that what that's really telling us is that we are ready to engage in a proper conversation about the future of our health service. We are ready to share our insights around that. And this is the power, the energy that we collectively now need to start unlocking. And just to give you an example of kind of how important this really is, in Hull, there had been a sort of rumbling problem where the local car park attendant in the hospital was ticketing people who overstayed their welcome. You know, the 2 hours had come up and very ruthlessly get your fine on the windscreen. And there was a particular cohort of people who were finding this completely unacceptable. And that cohort of people were people who had just suffered a bereavement and had obviously therefore stayed on an unplanned basis by the side of their relative, I mean, quite clearly, and to find as they walked out of the hospital they were getting a car park fine. It was just really the last thing they wanted, and it was undignified, and it was disrespectful. So along comes the friends and family test, and for the first time those people are able to simply, transparently explain this is unacceptable in their comment, and within hours that was stopped, and within hours the car park attendant was stepped down from being ruthless about people who had suffered a bereavement. And the thing is, these small things, these small indignities are what, if we allow them to build, this was the essence of the Francis report, become big tragedies. So capturing these small indignities are a really important part of our data revolution as well. And there's a third piece to this data revolution, which is to do with allowing the patient to be the instrument of their own outcome measurement. So one of the other things that I found oppressive, and I think is wrong about the way we run our healthcare system, is we put so much reliance on the judgment of the doctor in relation to whether a thing has gone well or badly. And what we now need to do is transfer not just the availability of the data to the patient and the public at large, but also actually ask the patient, if they want to, or the parent, to become an instrument of providing data. And the example that comes home to me most prominently is cleft lip and palate services. I have twins, now aged 3, who have cleft palates. And they had the operation. It was a really interesting conversation when they were very little with the surgeon about what he thought the outcome would be for those. What did he value as the outcome? And of course his concern was that the surgical outcome was safe and that they weren't harmed during the course of the surgery. That was not my concern at all. My concern was obviously how would their speech develop in relation to their peers? And actually that data in 8 out of 9 cleft lip and palate service networks in this country is not collected. And that's because the patient hasn't been given the right to say that's important, and the parent are given the right to actually record it for themselves, and that becomes part of the clinical process. So what's known as patient-reported outcome measurement or patient-centered outcome measurement, I think, is a really important part of this, and you'll see over the next few months some very big developments in that regard too. So just sort of in closing, in a way, this data thing is fundamental in so many different ways, but really it's fundamental to liberating us as people in our health service. And without this data, we can't do really important things like, for example, have access to our medical record, because there won't be digital medical records. We can't think about interactive care planning sensibly without this data flowing accurately through the veins of our healthcare system. We can't imagine a world where people are able to choose their local commissioner. A real priority for me, and I know for our chief executive, how can we give people the chance to have a much, much greater degree of control over who it is who's buying their services for them? These all depend on really good data. They depend on transparency. They depend on us having the tools to be proper patient leaders for ourselves. I'm going to finish with one story, which is a story about how data has yet to deliver and the gap between where we should be and where we are is. And this occurred the day after I'd just been in the Olympic Village with Arvind. I met a guy called Monza who has pretty severe learning difficulties, but is a patient leader, very articulate advocate for this revolution. He just happened to be in the hotel I was staying in. He was there on holiday, and I was just doing work nearby. And he asked me whether or not I had delivered on a promise I made a year ago to find a way of ensuring that that data about people with learning difficulties was distinctive, so that when they went into hospital, when they were admitted for emergency treatment, somehow the system would know that they had learning difficulties and cut out a lot of the administrative burden and process they have to go through to get through a hospital. I mean, he, as others, often will have an emergency, wait a couple of hours in A&E, and then have to wait up to sort of 3 or 4 hours after he's gone from A&E while someone fills in a form, to go buy a bed, to wait for a hoist to arrive, to take him out of his wheelchair so that treatment can be administered. And the indignity and the sometimes painful 5 hours or so he can sometimes wait because the system doesn't know who he is a scandalous inequity. So he asked me a year ago to pledge that I would make a difference to helping the NHS remember people. And I haven't done that. And I haven't done that because I've done a lot, but we have not yet done that. And I hope next year I can come back and tell you that not only do we have a data-rich NHS, we have a data-rich NHS that can actually remember the people it's treating. And by then, maybe, that might be a symptom of our data revolution having got to a level of real maturity. So thank you very much, and I just hope we can all really engage and promote this concept of the importance of data in our patient-led health service. Thank you.